Sorry, we're getting a little bit of a late start. It's that kind of a day. Everybody here, we have a quorum now. We definitely have a quorum. Thank you very much for everybody for getting here. And first up, we did put a sign-up sheet. Did you put it? Where did you put it?
Right there.
It's on the podium. If anybody wants to sign up to speak on the bill, and if you don't get there in time, come on, sign it. It's fine. We'll grab it later if somebody comes and wants to sign up. Okay, we are going to take up first House Bill 586. It is, Kate, if you don't have to catch a plane or anything, right? No, ma'am. On a time limit, okay. Okay, Representative Estration, if you will come forward and present your bill.
Thank you, Madam Chair, members of the committee. I'm here today to present to you House Bill 586. It's LC 480085, which is as introduced. So Georgia, like many states in the entire country, is suffering from the opioid epidemic. Very strong prescription medication is prescribed appropriately many times, but it ultimately falls into the hands of individuals who are seeking to abuse these prescription drugs. And it's a very serious problem that we face in all of our communities, urban, suburban, and rural Georgia, throughout our state. The cause of this House bill, Madam Chair, is a constituent of mine had a family member who was suffering from addiction and whose spouse was in the final stages of cancer. When the spouse passed away, very serious, strong medication remained in the home, and that ultimately was abused and led to this constituent's family member's death. And that was what really brought about this issue, brought it to my attention. But I am familiar also from personal experience about strong medication that is in a home as part of hospice. So what House Bill 586 would do would allow for hospice workers, upon the passing of the patient, a hospice worker may take back the prescription medication according to rules promulgated by the department. So there'd be very specific rules. There's no obligation to take it, no requirement that the house be searched for drugs, just that the hospice worker is permitted, if it's agreed to, if they agree to do so, is permitted to take the medication back and must dispose of it according to rules promulgated by the department. And this is really because I think a lot of family members don't know what to do. You've gone through the tragedy of watching your family member struggle and pass away, and you then have this very strong medication in your home, and that's really the last thing on your mind. What do I do with it? So I brought a few helpful documents I believe will be helpful with me today. And the first is from the Food and Drug Administration website about where and how to dispose of unused medication. So in my family's experience, we were able to identify the local sheriff's department had a depository box where you could take medication for it to be received and disposed of. But that isn't an option for everyone throughout the state. And so there are some recommendations. You can see the first is the drug take-back programs, which is on here, but there are some other options about how to properly dispose. And I thought this information was very helpful. People ask, is it okay to throw drugs away? Can I wash it down the sink? Is that going to contaminate the water supply? These very good, appropriate questions. There is available information for what to do along these lines. The objective here with this legislation is to also fill a gap in existing regulations from the department. So, and I've been in communication with the department and have the regulations and the proposed regulations, and there is not anything, and they can hopefully are here and can correct me if this is incorrect, but there is not anything that specifically and explicitly would allow for them to take possession currently, and this bill, if passed, this statute would provide clear recognition by the General Assembly that hospice workers may take back these prescription drugs consistent with rules set in place by the department. I think that a common question or concern might be, well, what if a hospice worker is going to take these drugs and misuse them or misappropriate them? What do we do to address that? And the objective here is to allow the department to put in place restrictions to ensure that that doesn't occur, and also to be able to address any of those concerns in real time. In other words, if we are seeing a problem with how it's being used, for that to be addressed with the department immediately, not for there to be a waiting period for the General Assembly to be back in session to address how to fix that issue. It's very important concerns, and I really welcome and appreciate the debate, but I do believe we have an existing gap in the law that needs to be addressed in this area, that we can do a great deal of good for Georgians who are going through very difficult life experiences, and finally, we can address the opioid epidemic, and prescription drug abuse, which is a problem throughout the country. The final thing I'll mention is this body passed House Bill 897 in 2016, and this established a statewide drug repository and allowed for provided conditions for that establishment, and also had some other language as to recycling medication and things like that. I've passed out a copy of that House bill so that you can receive it, but the thought is that maybe this legislation, if passed, could work in concert with the state drug repository so that these prescription medications that are received can be appropriately disposed of through that program. I'd be happy to answer any questions.
Representative Hutchinson.
Hi. Thank you, Representative. Thank you, Madam Chair. The big red flag for me here is healthcare workers are amongst the top, some research will say the top 10 highest professions with the highest instances of drug use. So if we have this bill which says that the rules are kind of, we'll make it up as we go, that would be a concern for me, because we're putting a population of people in direct contact with heavy drugs, and we don't have anything in place for that right now. And I would hate to put them in that situation or leave it open for them to have access to really heavy drugs, because I worked hospice for 2 years, and I know how much drugs are available. So that's a concern for me.
I think that's a very legitimate concern. I completely understand your concern, and I share it. I think that the department is I would just respond by saying I think the department is in a unique position to ensure that under this operation that there is a procedure in place to minimize or reduce any potential for misuse or misappropriation. Of course, that's a concern that we always have, even prior to the patient's death. And so understanding and appreciating that in the context, I would submit this is a very measured, reasonable effort to try to address a problem that we have, but I certainly share your concern and understand it.
Representative Hutchinson, if you worked hospice, did you have to have a background check?
Yes, absolutely, all the
Okay.
time.
And does everybody, I think I know the answer, but I'm trying to, for the public, everyone has to have a background check?
Background checks don't include substance abuse, though.
Well, right, I
Unless-
know.
yeah.
Unless there's a history of substance abuse, I understand that.
Yeah.
Who is usually at a death from hospice?
Who's that, what?
Who comes, is it my understanding that a hospice nurse or somebody from hospice is usually called when a person is nearing death or has died?
And the social worker and whoever else, the family. Sometimes there are volunteers, there's staff that they might be close to, they may not. So there's a list of people they call when it's closed.
Okay, but does somebody come from the hospice?
Usually, if there's time, yeah.
Do they come, even?
Yes, they have to, someone has to come to what do you call it when you certify that they're the death?
Coroner.
No,
No.
they,
Would have to be a,
yes, they have to call the time of death. So I think as a doctor or nurse has to do that,
from hospice?
from hospice, yes.
Okay. All right. Because the question I had is, and I think, I asked you ahead of time, is I would like to see it shall pick it up. And you said the department had some problems with that.
I don't want to speak for them, but I did have a chance to talk with them ahead of time, and I think that they would be concerned with they can correct me if I'm wrong, but they would be concerned with the shall language, and that may is was viewed as a I think from all involved, may would allow for implementation only if everything else is worked out. An obligation placed on these workers could be viewed unfavorably. But I will just say that matter is the will of the committee. I'm not opposed to that language change.
And in a little while, is somebody here from Public Health or from the department? It would be, okay.
Hi, I'm Brandy Sullivan, Director of Government Relations for the Department of Community Health. We did meet with Representative Efstration yesterday about the bill. We don't have any concerns with it as written. As to the question regarding shall versus may, I'd prefer to kind of work with our subject matter experts to give you an analysis of any concerns we may have with that change.
Okay, well, there is a drug available, I call it a drug, that you just mix with a little bit of water and the narcotic, which could be done at the site, and it becomes something you can just throw in the trash can. And so if that was the requirement, the drug could be destroyed right there. But, and so you're opposed to the shall, or?
So again, I would want to get that written up by our subject matter experts. I'm not familiar with what the immediate concerns would be with that change.
Have they expressed concerns?
I'm not.
No, so it's not that somebody's expressed concerns, you just haven't.
I have not personally heard those concerns, no.
Okay, all right, let me go. Representative Mitchell.
Thank you, Madam Chair. I'm glad you're standing there. Representative Efstration has come up with a thorough presentation, and I'm glad to hear that he talked to you. I'm interested in knowing what effect this will have on the department. You're promulgating the rules. You're going to presumably have to enforce them, and what effect this will have on your department as far as personnel is concerned.
I mean, we'd certainly work on promulgating those rules and work with, I understand that there are concerns from both sides. We'd work with the advocacy groups, the providers, to make sure that the rules are addressing the primary concerns. But yeah, I don't expect that would be a huge administrative burden to change those rules.
Representative Newton.
Thank you, Madam Chair. I kind of want to point out, I appreciate the law being, the verbiage being the way you have it, in particular that the department can come up with the procedures. As the chairman just mentioned, there's new products being developed to help with this problem. And if we had codified it one particular way, then we would have to be coming back and changing it when it's, say, a new product that does a better job. So I appreciate the department having the freedom to do a best practice, to promulgate rules and regulations. I know that there are guidelines, I know with the nurses that I work with in the emergency department, as the chair lady is familiar, that certain things have to be witnessed when you dispose of them, whether it's mixing them with something or coffee grounds or flushing them. There are certain guidelines that could be written to say who has to, when you're disposing of narcotics, you can't just go in the bathroom and flush them and say you flushed them. You have to have somebody watch you who signs with a certain certification. So those already go on, but I appreciate the fact that I think the department is really a great way in this particular case to allow the freedom to come up with better practices if they come along, but at the same time go on and give that option really quickly for, like you say, these large quantities of very needed pain medicines and opioids in particular, to give a good, safe alternative. I appreciate the bill.
The only trouble with that, Representative, is it says may, not about how the rules are written about it, but it says the hospice care team may. So it leaves it up to whether, John, do you have things that you do? And so he might decide that he doesn't want to fool with it and doesn't let his workers. And so those medicines are not picked up or where it's a problem. So it's difference not in how the rules go and how they do it, but whether the hospice can decide for itself whether they want to do it or not. So, all right, Representative Sharper.
Thank you, Madam Chair. Thank you for this bill. I just want to go on record as possibly giving some type of suggestions in this. because, we go to some patients and, you usually have a nurse, like she's saying, that's going to confirm. Every worker really works for an actual company.
You like to back-
So the responsibility, I think, would be on the company to also have their guidelines, standard operation procedures, that if you go to a home and when you confirm, on your checklist would be look for medications, get those medications, take them back to whatever company that you work for, and have somebody there confirm that you're actually disposing of them, or whatever you guys come up with. And I think the liability there would be something that can be confirmed as well about the drugs, instead of them at home getting rid of them and the nurse say, I got rid of them, but you didn't, But I just want to go on record as that could be a possible suggestion to make sure is in the operation procedures for the company, and is a checklist for the person that's going to confirm the actual death to get the medicines. Yes. Yeah, the nurse take it back to
Representative
where they
Henson.
work.
Okay, I have few questions to ask. Is you're dealing currently we're dealing with the feds because they have promulgated rules and regs, or rules, I should say, that have to be followed. Secondly, I thought a lot of this was under DEA, not DCH, with disposal and all. So I'm just wondering how it suddenly got to DCH instead of DEA.
I think Department of Community Health would administer the rules for this area of state government, of state regulation, and drug enforcement and other federal programs. Food and Drug Administration would provide federal guidelines for prescription drugs. I don't know if that answers your question.
But all of these are prescription drugs, so what's the difference? I mean, why are we are they going to conflict with each other? Are they going to communicate? I mean, I just really wonder why we're suddenly moving to DCH instead of staying with DEA and working with them. The second thing that I will mention is the new disposable things. When I went to a Women in Government conference, they had some of those. I mean, of course, you put them in, you add some water, and the pills aren't good anymore for what folks want, and those are new things coming on the market.
I think that's a terrific point, Representative. I'm familiar with new technology that, as Madam Chair mentioned, you drop a tablet into the pill bottle, add some water, shake it up, and it's neutralized.
I can
And
bring
you're-
one of those kits in,
Yes, ma'am.
next time. But I'm going back to why are we DCH instead of DEA?
It's my understanding DEA is a federal agency, and this is state legislation to allow for this to be done in the state of Georgia, and we regulate this industry in the state of Georgia. And the Department of Community Health provides regulations for hospice workers, so this is the appropriate area of the code, and it's the appropriate department to include.
Thank you.
Yes, ma'am.
Representative Pruitt.
As being a witness to this, I think this is great legislation. And I'd like to just possibly introduce the idea that where it says hospice care and change it to shall. And then as we read on through prescription drug prescriptions to a patient that are within a patient's home, and let's see where I went here. And at the time of such death shall be done in the presence of a witness, and witnessed by and signed affidavit by a witness. If in such the member's home at such time the death is in a home, the department shall promulgate additional rules. So you basically have something in place that's hard and fast currently, but it still opens up an opportunity for you to add additional rules provided things come along in the future. But it also puts the department or whoever's there, the hospice care, that they have to have a witness to sign off that they saw them dispose of it. Just an idea.
These are all friendly amendments in my view. I will mention on the shall, I failed to mention this earlier, but there was some question as to an obligation to search the home, to find medication, to really search out. And the concern might be that if it's being hit, there wouldn't, we don't want to shift some responsibility to hospice workers to have to search the home. Or
I
to
agree.
identify there's some, so, that's a very friendly amendment. I have no issue with the language you've recommended as far as the witness.
Okay, I'm going to make this the chairman's prerogative. I think you need to go back and you've heard some of the things. Let Representative Schofield, and who's 27?
Chair. So just have a quick
Hood.
question.
Okay, I'll get
I'm
you, John.
curious that there are a lot of other home health care entities, and so why just hospice? Anything you can do in the home. So when we talk about other professions providing care, like occupational therapists, practicing nurses, physical therapists, it just seems like we're just picking hospice as opposed to. So why aren't there others included?
Well, the reason is after a patient passes away, the person to whom the medication was prescribed is no longer there to take it. And so if the patient is living, then presumably the medication would still, is prescribed for that patient, and the patient is able to take the medication. So I'm not saying that we don't need to look at in-home health care in other areas, but it's just very clear that when the patient has passed away in a hospice framework, then a hospice worker, in my view, should have the ability to receive and dispose of the medication. And so that's the reason I've just identified hospice workers in this bill. Thank you.
When a person goes on hospice care, the medications are sort of monitored and taken over by the hospice nurse, and they oversee, when you go over off oral, or like if there was morphine, when they up the morphine dosages, it's communicated to the hospital, the hospice nurses. So that's why they've been responsible for checking on this patient and working with them through the dying process. So that would be the reason for that. Representative LaHood.
Thank you, Madam Chairman. Thank you for the bill. I think it's a good bill. I think allowing hospice the option to dispose of these controlled substances will definitely help, keep some of these prescriptions out of the wrong hands. I like the word may better than shall. You brought up a good point. When we mandate that hospice should dispose of these medications, where do you stop? How liable does that make hospice if a medication is not discovered at the time of that they're in the home? And after hospice leaves the home that last time to pronounce the death, they're not coming back. And so I'm in favor of allowing DCH to develop rules and then requiring hospice to follow those rules.
Thank you.
Okay. And while we're doing that, we're going to send him back to do this, John. It's still going to be whether the company wants to do it or not. So even though the department promulgates the rules, they may be promulgating rules and everybody says, well, I don't want any liability or something. Or do we write a bill? It's just something to think about. Do we write a bill that takes away the liability from the company or whatever? I think we need to talk about this.
Okay.
Okay, and John, can you get with me and with everybody?
Certainly.
You've heard the things, how we might make it more palatable, because I think you might just have everybody say, I don't want to do it, and we still have a large amount of narcotics sitting around for somebody to take, if the objective is to make sure that the drugs are out of the hands of people other than the patient. I don't know.
Right.
Let's work
I
on it.
definitely agree. This bill is a step in the right direction, in my opinion, and I think most hospice agencies are going to want to do what they can to remove these medicines from the wrong people having access to them. I think most are going to just do the right thing. This will greatly improve.
Thank you.
Okay, we
the
have one
current
more.
situation.
Representative Sharper?
I'm going to be very brief, but listening to some of the comments and some of the questions, I think what has happened here, what you presenting is something that is kind of specific for more your controlled substances, because somebody was asking, what about this particular person that goes to the house when somebody dies? But the difference of the drugs, a lot of times, the controlled drugs, the hard drugs that people are really, not just your blood pressure, diabetes medicine, things like that. So that's why I think it's more in your direction of what we're talking about. So I think we don't need to broaden this thing and saying the coroner need to be in charge of some drugs, or anytime anybody died at home, we need to have somebody that comes in and just get all the whole bags of drugs. That's not what we're looking at, and that's why we don't need to go that way. That's what'll mess the whole bill up. We got to go specific on, we see that the opiate situation, and it's considered the hard drugs that people are after. And like he's saying, the hospice patients, they have a lot of that type drug. So let's not get too broad and get away from what he's actually trying to do.
Thank you.
All right. Okay, we have a couple people who'd like to speak on this bill. Sheila Hummerstone?
Good morning, good afternoon, Madam Chair, members of the committee. Thank you for allowing me to speak to you briefly today. My name is Sheila Humberstone. I'm actually not here on behalf of any of my clients. I'm here in great support of this bill. I think it is wildly needed. I've got a personal story to share, if you'll give me the time. I had a dear friend who's in her mid-40s, and her husband died at home of brain cancer. And I was in the house when he passed away, and I was petrified of leaving her alone in that house after he died with the amount of medications that were prescribed to him rightfully. He needed those medications, but at the point that he passed, that medication was no longer helpful. It was wildly dangerous to be in my friend's possession. So what I did is I took it. I took it and drove home really slowly. I hope the statute of limitations is up. And I disposed of it. But it was scary for me to be put in that position where I felt like I needed to break the law and take the medication home and dispose of it. I couldn't take it to a drop box because that was further away than where I lived. And I was afraid of being pulled over and having a trash bag full of medications that did not have my name on it. And so I appreciate you bringing the bill. I appreciate your thoughtful consideration on this very important issue. The only other aside I would say is, as we're stepping into this arena, we're learning as we go a little bit. And I think there is some benefits into punting some of the specifics to an agency that can in real time make changes as we learn. We can start very tight and then gradually loosen it, as opposed to having to wait for a whole nother legislative calendar to come back here and finish it. So I thank you for your time, and I thank you for your consideration.
Thank you. Thank you. Tom Bauer?
Thank you, Madam Chair, members of the committee. I'm Tom Bauer, and I'm not going to talk about opioids, Madam Chairman. I'm also here for myself, and I have a similar personal story. My father-in-law was in home hospice and passed away. And while wasn't really fearful that my mother-in-law was going to consume the drugs, she really wanted to know what to do with it, and she had no idea. So I think when we were working on Representative LaHood's bill that you helped us with last year on the assisted living, giving patients there the same privilege as at home, I think this is a good follow-up and needs to be looked at. Thank you.
Okay. Okay, so Representative Strachan, I think get the department to talk to me, and I think maybe if you talk to Jimmy Pruitt too about the bill does say prescription drugs. That could be anything from an antibiotic to a heart medication, which really nobody should take, but I think that Representative Sharper does make a good point in saying that what we're really trying to get at are the opioids, often morphine, which is often available to dying patients, and a very strong opioid, so maybe limiting it in opioids. And if you consider it and talk to LaHood, John, about if you want to do it in the hospice, I would think that in home situations, maybe being a little bit more specific and work on it that way and come back, and I'll give you a hearing just as soon as you come to terms and get the bill revised.
Thank you, Madam Chair and members.
Thank you.
Thank you very much.
Okay. Representative LaHood? Okay, and Representative Pruitt, if y'all will talk to him about it and see what you can come up and be more specific. But we are talking about opioids. You know, they wouldn't necessarily have to be twos, but, you know, anything on the opioid level, I think, and morphine and all. Okay. Kate?
Yes.
Kate Blackburn, come up and tell us who you are and
Thank you, Madam Chair and members of the committee. My name is Kate Blackman. I am the Director of the Health Program at the National Conference of State Legislatures, which is one of my jobs. And then my other job is that I'm the liaison to the Georgia General Assembly from NCSL. So Chairman Cooper has graciously let me do play a little bit of both my jobs and both my hats to tell you a little bit about NCSL and then a little bit about one of our projects that some of your colleagues took part in and that you're going to hear more about from Lisa Dawson. So, but I'm going to keep it real brief. I hope you all know that NCSL is your organization. We are the bipartisan membership organization of all state legislators and legislative staff. And so one of the things that we are able to do for you is to provide any sort of technical assistance that you may need in your job. So I'm coming to you from Denver, where we have a huge staff who are here to answer questions from you all on a daily basis. So I lead our health policy work, but I also have colleagues who work on all the other committees that you all may serve on, and that your colleagues serve on: transportation, education, criminal justice, and other things. So our mission is here, you see it, but I just want to reiterate that we are here to serve you and that you can call or email us at any time, and we are here to provide research for you. And so that's part of my liaison role, is that I am a point person for you should you have a question and not know where it needs to go, that I can help connect you to those resources. So just, again, a little bit more about what we all do. I hope some of y'all have been to our meetings, to the National Summit or other meetings that we have. And again, but I just want to point you to so much of our resources that exist online. We have tons of legislative databases and, again, tons of research and expertise in our shop that I encourage you to take advantage of. We don't take any positions on state policies, so I do want to make that really clear, both for the purposes of my being here today, but also in general as you reach out to NCSL and you connect with our resources. We're always happy to provide you with examples of how other states are tackling things. I do believe we've seen other states looking at the same issue that you all were just talking about in the bill that was just presented, so you could call me and say, Kate, I want to know what the language looks like in those other bills. Is it shall or is it may? And we could
Can you send those to me, please?
Yes. Yes.
Whichever states have passed this law.
So that's an example of the type of service that we're here to provide for you all. And I really encourage you to take advantage of it because you are all members of NCSL, as I sometimes say, whether you want to be or not. But I'm actually going to transition a little bit to talk about one of the efforts that took place this past summer, the Winnable Battles Project. So wearing my health policy director hat, we convened a meeting in July with the Association of State and Territorial Health Officials, or ASTO, and the Centers for Disease Control and Prevention, or CDC, which I assume you all know being here in your backyard. And that was around the CDC's Winnable Battles. So Winnable Battles are public health issues that that CDC has identified are areas where, we know that there are proven interventions or evidence-informed interventions or policy options, and that we can make progress to really prevent or address them in a relatively short time frame. And so what we do in our partnership with CDC, NCSL and ASTO's partnership with CDC, is that we bring, for the past almost 10 years now, I think, we have bring together state teams from different states. So, and those teams consist of the legislative branch and the executive branch. So we come together for a few days, we learn about what's going on with specific public health issues, what are some of those evidence-informed options, and then the team really meets and says, this is what's important to us in Colorado, or this is what's important to us in Georgia, and this is what is realistic for our state. Every state is different, and we know that. And so the teams really think about what makes sense for them and develop their own action plans. And so the meeting that just took place in July focused around adverse childhood experiences, HIV, vaccine-preventable diseases, and infectious disease related to the opioid epidemic. So increases in HIV and hepatitis and as a result of injection drug use related to the opioid epidemic. And so you had some colleagues from Georgia who were part of this team. So we're here to share a little bit about that with you. Chairman Cooper was on the team, and Michael was on the team, and Representative Hogan, who has stepped out, was also on the team representing the House. And then Senator Lester Jackson from the Senate and Elizabeth Holcomb from the Senate Research Office. So you had a great legislative team, and then 2 folks from the Department of Public Health, one who you'll hear from here in a moment. And the Georgia team identified 3 priority areas, which you can see. And the one that I'm here for today is really around adverse childhood experiences. And so that was something that was talked about a lot at the meeting, kind of as an underlying, the adverse childhood experiences that you'll hear more about from Lisa, but things that happen in childhood that can affect our trajectories and affect later health and well-being really can affect things like substance misuse and some of the other issues of concern. And so one of the things the Georgia team said is, well, we're here learning about all this great information. We think this is really relevant and important in Georgia, but we want to share that with our colleagues, including other state legislators. So here we are, and I'm thrilled to be here with you just to introduce this idea to you. So where you take it after this is up to you. It's up to the state, but we did want to share that with you. So you'll hear from Lisa, who's going to tell you a lot more about what's happening with adverse childhood experiences and the data in Georgia and what the Department of Public Health is undertaking in the state. But I do also, before I go, I have to give more shameless plugs to make sure that you all know that we're here for you. My contact information is there. You also received an email from me last week. And then NCSL has been doing a lot of work around adverse childhood experiences in particular. A lot of lawmakers across the country are interested in looking at, kind of how do we prevent adverse childhood experiences to affect other things that we really care about. So we have a couple resources here on that as well, and I'm happy to answer questions or be around. I'm here till Thursday, so happy to be around as is helpful to you all. And Chairman Cooper, if there are any questions, I'm happy to take them, but.
Nope. Okay, well, and let's see, who's presenting on?
Miss Lisa Dawson.
Lisa Dawson. Oh, there we go, Lisa, sorry.
Oh, thank you, Madam Chair, and thank you to Kate for such a great introduction to the work we did with Chairman Cooper and the other legislators and legislative staff this summer. It was a really great meeting, and so thankful and grateful to Chairman Cooper for wanting to learn more. My name is Lisa Dawson. I work with the Georgia Department of Public Health. There a couple of things. I'm really just a representative of a larger working group. There are multiple agencies and organizations who are working on adverse childhood events in Georgia, and I'm going to talk about that and give some shout outs to our partners as I go here. And with these 10 slides, what I'm hoping to do is kind of give you a snapshot of what ACEs are, their consequences, and some of the policies that the legislature might consider. So there are 3 graphics on this slide. And the first one shows types of ACEs, kind of 3 buckets, if you will. Abuse, neglect, household dysfunction. We're going to talk about a 4th bucket in a little bit that was not part of the original study. The second is the demonstrable risk that comes with being exposed to ACEs and the bad outcomes that happen. Let's see here. And then the third is that 1 in 6 adults have had 4 ACEs or more. So those are the 3 graphics up there. So where did this come from? In 1998, there was a study by Dr. Anda and Dr. Folletti. CDC and Kaiser Permanente got together in California, and they surveyed 17,000 of Kaiser Permanente's members. And what they were essentially looking for were the root causes of chronic diseases. And so it's a little different than what we started out talking about, adverse childhood events and chronic diseases. Where is she going with this? So what they found was that the more ACEs that were present in adults, the higher risk there was for chronic diseases. And other bad outcomes. And so they were really intrigued by this, and they published a paper on it in 1998. ACEs are potentially traumatic events that occur in childhood. They can include abuse, violence, growing up in a family with mental health problems or substance misuse, ACEs can change the brain development of children. The initial adverse childhood events that studied do not compass, as I said before, all the childhood adversity and trauma. The fourth bucket is really kind of the community piece, and this would include things like gang violence, racism, bullying, homelessness, kind of outside the immediate household environment. So that's a fourth bucket that other studies and other professionals have included as well as ACEs since the original study. What ACEs does is it gets the body to produce toxic stress. And toxic stress is a physiological response, and that's what actually impacts brain development. So here are the negative outcomes negative health outcomes I was talking about earlier. Intuitively, when we think about childhood exposure to adverse childhood events, we think about acute and visible injuries to the child, but ACEs are associated with all these diseases in those same children long after they become adults. The impact of ACEs includes chronic diseases such as heart disease, cancer, and obesity. 5 of the 10 leading causes of death are associated with ACEs. Preventing ACEs and reducing them could give us some significant gains, which we're going to discuss in the next couple of slides. But first, I want to talk about the data and what we know about ACEs in Georgia. This next slide is the behavioral risk for Behavioral Risk Factors Surveillance Survey, better known as BRFSS. This map shows you all the states that have participated in the BRFSS, what years they participated in, and the states that did not participate. So it gives us a little bit of comparable data. This data has been collected from 2009 to 2018, and Georgia participated in the BRFSS in 2016 and 2018. So we have a little bit of data. Trends are good. The next slide is a little bit more about proxy data for ACEs. And the really important proxy data on this slide is the one about the National Survey of Children's Health. This is a nationally representative survey that gathers information on the physical and emotional health of children, families, neighborhoods, and schools in context. That's probably the most helpful of the national surveys that we looked at. And then the next slide looks at Georgia data in context with US data. So the two most important pieces here, oops, I skipped a slide. Oh no, I didn't. Okay, so the two most important pieces here are those 2 circles on the screen on the left-hand side. This is about percent of children with 2 or more adverse childhood events. Georgia actually ranks 36th in the US for the lowest percentage of children with ACEs scores of 2 or more. So this gives you an idea of where we sit. It's not the first, it's not the last, kind of the middle of the pack there. Let's see here. Okay. So, preventing ACEs and minimizing the effects. I apologize, I got something out of order there. So we can help children and adults thrive and potentially lower risk for conditions like depression, asthma, cancer, diabetes in adulthood. We can reduce risky behaviors like smoking and drinking. We can improve education and employment potential outcomes, as well as stop ACEs from being passed from one generation to the other. There are 3 tables on this slide. The first one in blue shows that if we could stop ACEs, or we could prevent ACEs, we could reduce depressive disorders by 44%, COPD by 27%, asthma by 24%, and I'll let you read the rest of the slide. The other 2 graphics on here are the second table in brown and peach shows the health risk behaviors that could be reduced. And then the third table in green shows the positive outcomes in socioeconomic indicators that could be improved. the way forward, these are some broad goals and recommendations that come from our friends at the CDC. Enhancing, while childhood adversity can lead to lifelong physical and mental health problems, adversity does not predestine children to poor outcomes, and most children are able to recover when they have the right supports, particularly consistent presence of a warm, sensitive caregiver. And the last couple of slides, I want to spend some time on this slide in particular because it's a placeholder. These 8 blocks are not all that's going on in Georgia. I want to talk about the Family Connection Partnership has supported Better Brains for Babies for more than 10 years. Work of Diane Bales at the University of Georgia has done this. Children's Healthcare of Atlanta has been building on this work and implementing positive parenting programming, and they're on their second module now. The Department of Education has trained over 20,000 educators in mental health awareness, including youth mental health first aid. The Department of Behavioral Health and Developmental Disabilities has trained over 525 individuals. I want to give a couple more shout outs to my departmental brethren. Division of Family and Children's Services, in partnership with Georgia State, has created the Child Welfare Training Collaborative, and this is actually something that the Department of Public Health actually serves on to help them guide their training and who they give it to across departments. And then, of course, the Department of Early Care and Learning has provided trauma and self-care to 448 field staff. So there is a lot of work going on. We're not starting at square one. I want to reassure you of that it's been going on for some time. There's the very first block up there is the Georgia Essentials for Childhood. That's actually a core team of folks who work unfunded to address ACEs in Georgia. So, and that's a department level, and we have several committees on that. So that's something that we've been leading. State actions and policy solutions. These are 5 states that have implemented either in code section or funding, or they've promulgated rules that have supported programs that support and prevent ACEs. So Florida, incorporating evidence-based trauma-informed services, making it in code section. Texas, this is, I believe, a promulgated rule. And then Tennessee, the legislature has put funding in for ACEs. Other ways to look at policy solutions, quality care and education in early life. I have to say my colleagues at DeKalb really knock it out of the park in terms of this. They've done a phenomenal job. Economic supports to families, we have some of these in place already. And then policies to support working families. This is something that is coming about. Things like on-site daycare, like Home Depot has, CDC has. Those kinds of things, paid sick leave. I need to give one last thank you and shout out, and that's to our staff who are here and watching, to the legislators who have been so incredibly interested in this topic, to our partners. They've been amazing. And the last thing I want to tell you is that if you're really interested in this, there is a screening of the movie Resilience. It is a documentary basically about the ACEs study. Our partners at Prevent Child Abuse Georgia are going to be hosting that screening at the Center for Civil Rights, and that'll be April 20th, 4:30 to 6:30 at the Center for Civil and Human Rights. I'd be happy to entertain any questions.
Do you have any questions for Lisa? Representative Pruitt.
Have you found, thank you, Ms. Chairman, have you found that there is a age determination of where you have the most success when you intervene, an age group?
That's a great question. Earlier is better because by the time kids are 13, they are only listening to their peers at that point. I mean, it's just really, earlier is always going to be better. This goes all the way to prenatal. bonding with that new baby when they're born. Those are really important things that we need to do. So there's different things at different developmental stages. So I would say not exactly. There's not a particular age.
Okay, but you work with those in your studies up through age 13. Is that correct? Is that?
Oh, yes, sir.
Okay.
And then what we've learned from one of our partners at Frontiers of Innovation, the Harvard Center for the Developing Child, is that really the brain has elasticity through age 18. But then once you become an adult, like past 21, you don't have that elasticity anymore. So really intervening earlier is definitely going to be better.
Thank you so much, Ms. Chairman. Could I ask
Yeah.
one more question?
Sure.
So if a child has experienced ACE and they're past the age of 13, and then we get into all kind of social issues, is there another group that's working on that, or we just count that as a lost cause?
There are always folks working on it. I wish Dr. Doyle were here from DJJ. She has about 6 years ago, the Administrative Office of the Courts allowed us to travel the state. They got a grant. They allowed us to travel the state as a panel from each of the agencies, and I went for Dr. Fitzgerald at the Department of Health. But I served with Bobby Cagle at DeKalb, Christy Doyle from DJJ, and some other professionals, R.E.M. Weldon at the time, Lee Ellingson. So what we were able to do was we were able to start raising the awareness of ACEs and doing trauma-informed work. We would never write a child off, but as the child progresses through the system, there are different interventions to help address that.
Thank you.
Yes,
Thank
sir.
you, Madam Chair.
Okay. Other questions? Okay, basically, okay. Representative Hutchinson.
I have a question about, so in mental health, the kids that we are the most challenged with are the ones that have all the checks by the time they're 16, and there's very little in Georgia that we can do with a child who's had this many and the amount of trauma that they've had. Is there anything that's being done? I know if we have a child who's very severe, we have to send them to South Carolina. Is there anything in Georgia, any initiative in Georgia that would offer treatment for that level of need?
I would have to defer and talk to Dr. Doyle at DJJ about that. I'm happy to follow up on that for you.
Thank you.
Yes, ma'am.
Okay, sort of to sum it up, as the family unit has broken down for whatever reason, and our communities are not as close anymore, we listen to teachers tell us that the problem they're having in the classrooms is the problem they're having because of the family breakdown and the home situations and the violence that children see. And one of the reasons I wanted Lisa to come is that we are doing a lot of things to fight those issues. And I don't think that we ever hear about it or we think about it in context that we are, as a state, trying to address these issues through the Department of Juvenile Justice, through Healthy Mothers, Healthy Babies, as they, push prenatal care and send out books for children to read, and they teach young mothers how to be mothers and all. So I wanted to come because definitely, and I think the one page that's so important is the percentage of children 0 to 17 years who have experienced 2 or more of the following really traumatic issues that cause so much difficulty in later life. But as we pass legislation and work on issues, we don't always, we think they're taking care of one problem, but they are toward the future of changing the lives. So that's why I had her come, and I think why NCSL and across the country they're working on these issues. So thank you very much for coming and presenting them, and we'll continue to try to help as we move on legislation and funding for different programs. So thank you very much.
Thank you.
And we are through for the day, so we are adjourned.